Hi, I'm Jordan Hudson. I'm an anesthesiologist at TOH, and I'll talk about handover today. So I became interested in handover a few years ago. We did some research looking at handover of care in my own specialty in anesthesiology, and we found that at the Heart Institute, patients whose anesthetic care was handed over intraoperatively did worse. They had worse outcomes, which was quite surprising to us. They actually had a 43% greater chance of dying and a 27% greater risk of major morbidity if we handed over their care intra-op, and that was after adjusting for the usual factors. So we were quite surprised by that. That's been supported by other studies in the literature, and handover of care in general has been an issue that's been a very hot topic for the last decade or so. So back in 2005, JCO released a study that showed that communication failures were the root cause of over 60% of sentinel events. So these were significant events causing patient safety risks or patient safety harm, and over half of those communication failures occurred during handover. So that's pretty huge. 30% of all patient safety negative events are related somehow to handover of care. So a lot of folks have been doing a lot of really good work trying to see, can we make this better? Can we improve it? Unfortunately, we haven't been doing a great job of teaching it. When I was a medical student, we didn't really get any training on handover of care other than what we got on the job, which was very variable and changed a lot. And unfortunately, even back in 2003, the Canadian Association of Interns and Residents did a survey of all residents across Canada, and they found that 83% of residents were getting no formal handover training, and this was 2 years ago. 70% had no standardized handover process, and about half of them had witnessed or had been involved in a preventable adverse event that was related to handover. So this is a big problem, and unfortunately, even as recently as 2 years ago, we haven't yet done enough to fix it, but we're working on that. So the CanMed's 2015 roles and the Collaborator role include a section on handover. It's item 3, and effectively, and pardon me for reading this, but it's to effectively and safely hand over care to an appropriate healthcare professional. Now handover, we think of it as physician to physician, on-call person transitioning to the next call person, but handover is much bigger than that. So handover is patients going home from hospital safely and being admitted safely. It's handing over between different members of the healthcare team, so both nurse to nurse, OT to OT, but also multidisciplinary handovers within the team, and more on that later. So lots and lots of handovers occur for every single patient every single day. When you look at some studies that were done, and this was published in JAMA last year in a study of internal medicine, 40% of clinically important issues were omitted during their morning handover. So this is a structured session where everyone's on the same page, sitting together, talking about patients, and they missed almost half of the clinically important issues. So again, more work to do. And more importantly, handover is a verbal process, but it's also very important to document what's being discussed, and that will also allow to jog your memory as well for people later. 86% of the information that was missed was not documented in the chart. So again, need for a little bit of standardization and a little bit of improvement of how we do things. Now, the good news, I told you lots of bad news already. Last year, a very big study came out in the New England Journal of Medicine that showed across multiple hospitals that if you implement a standardized process to handover of care, you can decrease medical errors by 23% and decrease preventable adverse events by 30%. So all we have to do is standardize our handover, and we can make a difference and make handover safer for our patients. So there are 5 components to an effective medical handover, and not terribly surprisingly, these are very similar to the 5 most important components of handover in other industries as well. So this is NASA, nuclear power facilities, ambulance dispatchers, railroad dispatchers, almost the identical 5 key components to a safe handover. So in their article in JAMA, Starmer and her colleagues identified these 5 key issues. The first is standardization, and you're going to hear more about that in a minute. The second is to limit interruptions. So obviously codes are codes, and emergencies have to be dealt with, but otherwise, no taking non-urgent pages, no people coming and going, having a quiet, uninterrupted environment. The whole team should be present so that anyone with extra information or clarifications can provide it, and so that the whole team makes sure they're on the same page. That it has to have 2 components, so both that verbal, face-to-face discussion and a written or preferably electronic component. And finally, there has to be some sort of quality assurance process. So the opportunity for people to speak up, to say, I missed that, or some sort of audit as to how thoroughly handover is being done to ensure that the information you think you're giving is the information that the person you're handing over to is actually getting. So there are a couple of ways to standardize. Two of the systems that you'll see are both the SBAR system and the IPASS system. So I'll talk about SBAR first. It has 4 components. SBAR came out of the military, and it is still the one being advocated by the Safer Healthcare Organization. So that's your situation, your background, your assessment, and your recommendations. Now these are lots of information online about SBAR and how to teach it, both in the healthcare setting and elsewhere. It's also referred to sometimes as ISBAR, with the addition of an I for identifying yourself, so making sure that everybody knows who they're getting their information from. So lots more of that available in information on that available in other sources. And the second commonly used tool is one that, again, just came to attention in the last year or two, and it's the IPASS tool. Very, very similar to SBAR or ISBAR, but there's IPASS stands for illness severity. So is this a very acute sick patient that you have to watch, or are they pretty stable? A patient summary, an action list, so what do you have to do? Situational awareness and contingency planning, so what bad things could happen and what should we do about it if it does? And then a synthesis by receiver. And that feedback part is very important both for closed loop communication, and you'll hear that concept coming up elsewhere in patient safety as well.